Welcome back to another explainer. Okay, let's dive straight in, because today we are looking at something truly fascinating. We all know our family doctors, right? They're the ones we go to for a sudden fever, some random unexplained ache, or just our standard annual checkup. But have you ever stopped to actually wonder what it takes to sit in that chair across from you? Today, we're breaking down a very specific document, the 114 Family Medicine Specialist Training Curriculum Standards. It lays out the exact training requirements mandated by the Ministry of Health and Welfare, and honestly, it reveals exactly how a medical graduate transforms into your absolute first line of defense.
3. That is the magic number here. I just want you to let that sink in for a second. We are talking about 3 full, rigorous, literally non-stop years of a highly structured training timeline. This isn't just some brief orientation after medical school. No, this is a multi-year gauntlet designed to build a master generalist from the ground up. Over these 36 months, these young doctors are pushed to their absolute limits across nearly every medical discipline you can imagine.
So, here's our roadmap for today. We're going to break this massive curriculum down into 5 digestible pillars. First, the specialist path. Second, the family med core. Third, cross-specialty rotations. Fourth, community and home. And finally, evaluation and research. All right, let's get to it.
Part 1. The specialist path.
You know, there's this kind of common misconception that family medicine is just about, well, knowing how to treat common colds or prescribe basic antibiotics. But to earn the specific, hard-won title of family medicine specialist, a medical graduate has to survive this incredibly rigorous 3-year residency program. They're officially designated as R1, R2, and R3. That's resident years 1, 2, and 3. And as you'd expect, each year demands an escalating level of responsibility and a much wider breadth of knowledge.
Moving on to Part 2, the family med core. This is really all about a shift in philosophy. Before these doctors even set foot in complex hospital rotations, they have to fundamentally rewire how they look at a patient. It's a massive shift in philosophy. The curriculum explicitly mandates what they call the biopsychosocial model. And what that basically means is they aren't just looking at the physical symptom, the biology of it all. They are trained to evaluate the psychological state of the patient, plus their social circumstances. They study behavioral sciences, they participate in these things called balance groups to deeply understand the doctor-patient relationship, and they integrate preventative medicine. They are treating the whole person, not just an isolated disease. It demands an incredible amount of empathy right from day one.
Now, to actually put this philosophy into practice, they need clinic time. The curriculum dictates this carefully planned, progressive escalation of their outpatient clinic responsibilities. In their first year as an R1, they're required to run 1 clinic session a week. By R2, that bumps up to 2 sessions. And by their final year, R3, they are running 3 sessions a week. It's a calculated, step-by-step approach to building up their clinical independence and, frankly, their confidence in making real-time diagnoses. And you can see it right here in point 19 of the ministry's text. It mandates that throughout all their different crazy hospital rotations, they still have to maintain this family medicine clinic presence. 1 session for R1, 2 for R2, 3 for R3. The government literally leaves 0 room for ambiguity here. They have to be seeing regular patients consistently throughout their entire 3 years. Which brings us to Part 3, cross-specialty rotations.
Okay, this is where the sheer volume of what they need to know truly becomes apparent. Notice the wildly varied pacing here, derived straight from the curriculum. They do these deep, multi-month dives into foundational areas, so 4 to 8 months in internal medicine, 3 to 5 months in pediatrics, and up to 4 months in OBGYN, but then, look at the bottom. They do these rapid-fire, intense 1-month exposures in surgery, ENT, dermatology, and ophthalmology. They are literally bouncing from the maternity ward to the surgical floor to the ER. It's an exhausting medical whiplash, but it is 100% by design.
Looking at this visual breakdown, you really get a sense of their focus. The massive chunks of time are dedicated to core life stages. We're talking adult chronic diseases, childhood illnesses, and pregnancy. But that remaining sliver of rapid exposures to acute specialties, that is equally vital. They need to know exactly what a standard skin rash looks like versus a really dangerous melanoma, or when an eye issue requires immediate specialist intervention versus just needing some simple eye drops. So what's the ultimate goal here? It's pretty profound, actually. They aren't trying to become neurosurgeons or top-tier dermatologists. They are becoming experts in being the very first point of contact. They're learning the absolutely critical first-line triage and initial treatment for literally any medical issue that could possibly walk through their clinic door. And for sure, that requires an impossibly wide net of medical knowledge.
Part 4. Community and Home.
taking things beyond the hospital walls.
Because let's face it, once they've mastered the hospital setting, they have to leave it. A family doctor's true domain isn't always a sterile hospital ward, it's the actual community where their patients live. The curriculum carves out a massive 3 to 8 month block entirely dedicated to community medicine, and it's incredibly modern. They aren't just learning standard checkups, they are training in large-scale epidemic prevention, which, well, we all know is absolutely vital nowadays. They're learning environmental and occupational medicine to figure out how a patient's workplace impacts their health. And they're mastering remote telecare and virtual consultations to reach folks who just can't come to them. And within that community block is a super strict requirement for home medical care. But look at how the curriculum actually defines this. It is not just a quick, polite house call to check a patient's blood pressure. The resident must care for at least 5 homebound patients continuously for over 3 solid months. This is about managing really complex, chronic conditions right in a patient's own living room for months at a time. It's a deeply involved, long-term commitment.
If we look directly at point 2 from the curriculum, the text is just crystal clear: at least 5 homebound patients for over 3 months. This specific, quantifiable metric ensures that these doctors truly grasp the realities of long-term care, the massive stress on caregivers, and what it takes to manage health outside the perfectly controlled environment of a hospital.
Finally, Part 5, Evaluation and Research. Basically, how do they prove they've mastered all of this? Okay, I know this slide looks like a terrifying alphabet soup, right? But let me translate these acronyms into plain language for us. OSCE, DOPS, Mini-CX, and CBD. These stand for Objective Structured Clinical Examination, Direct Observation of Procedures, Mini-Clinical Evaluation Exercise, and Case-Based Discussion. What they really mean in practice is relentless, highly supervised, and completely objective clinical testing. They aren't just taking written multiple-choice exams in a quiet room. Their actual physical interactions with patients are being watched, graded, and totally scrutinized by senior doctors.
Point 4 of the curriculum mandates these exact tools. To evaluate the resident's 6 core competencies, the evaluators aren't just looking for right answers on a piece of paper. They are scrutinizing concrete, physical abilities under intense pressure. Do they communicate effectively? Can they perform a physical exam accurately while someone is hovering over their shoulder? The oversight is intense, all to ensure public safety.
And honestly, the expectations go way beyond just passing those clinical tests. They're expected to be active contributors to medical science. The curriculum demands they participate in at least one research project. They have to attend a minimum of 2 hours of rigorous seminars every single week. And by their 3rd year, an R3 resident is literally required to spend at least 3 months supervising junior doctors or medical students. They aren't just learners anymore. They are expected to become lifelong researchers and teachers.
When we pull the whole thing together, the exams, the endless hospital rotations, the home visits, the research, it all circles back to this one core, beautiful quote directly from the curriculum itself. The ultimate goal is implementing human-centered, family-oriented, community-based medical care. That is the heavy, noble burden of a family doctor. It's just an incredible undertaking.
So we've seen the raw data today. The sheer volume of medical knowledge they have to synthesize across 3 years is absolutely staggering. So I'll leave you with this final thought. Next time you sit in that clinic because you have a stubborn cough or a weird rash, will you look at your family doctor just a little bit differently, knowing the intense 3-year multi-specialty gauntlet they had to survive just to be sitting across from you? Think about it. Thanks for joining me on this explainer, and keep learning.